there is a perception that the death was as good as it could be. And so here's some of the criteria, and these are reproducible, okay? Reproducible. Number one is a sense of control, including knowing and honoring the wishes of the one who's dying. We need to know the wishes to honor them here, okay? Here I am in the ER. Don't try to know the wishes here to honor them here. This is a time of chaos, okay? But if we can know them upstream, we can navigate it and have a soft landing. Number two is assuring comfort and dignity. That's all of our job. Number three is trust in the healthcare providers. I tell my patients, you can trust me. I also tell my lay populations, if you do not trust your doctor to talk to you about end-of-life issues, or you do not believe your doctor will appropriately refer you to hospice, fire them and find another doctor who will. The whole quality of your end-of-life experience depends on being supported by your physician. Next is recognizing and accepting coming death. Okay, so think about this. A good death is one you can see coming, right? So in contrast, a 20-year-old who's hit by a car, that's never going to be good. That's not, it's devastating. There's nothing good about it. I can't redeem it. But no 89-year-old with end-stage anything disease should ever have an unexpected dying. We should see that coming. That's an opportunity for a good death for the patient and the family. Honoring the patient's beliefs and values, a sense of closure, including words of goodbye. That's our 6 things. And then physical contact. They say that hearing and touch are the last senses to go. The VA, for as much of a bad rap as it is getting, is doing something right. They have a group called NODA, No One Dies Alone. And volunteers come and sit with dying vets and hold their hands, many of whom are alone or estranged from their family. What a priceless gift. So I'd like to end with a story, because I'm a different doctor than the one I told you about in 2010. I try to give my patients a good death. I try to talk to people about advanced care planning. I try to prepare people. And it's now easy for me. It's not scary, but it took a while to get there. And so about 2 years ago, I had paramedics call ahead. 60-year-old man, respiratory distress. I thought, oh, here we go again, right? So he rolled around the corner, and the gentleman had JVD to the roof. He had a BiPAP on. His pressure was 250 over 150. He had bubbles coming from his airway. He was in florid pulmonary edema. Too short a breath to tell me his wishes. He also looked chronically ill outside of this event. AICD-in, had an EF of 10%. So his wife was standing outside of the door, and I started a nitro drip on him and blah, 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 Lasix, this, that, morphine. And I opened the curtain to go find out his healthcare wishes. And there she stood shaking, holding his living will. I was like, oh, my people, somebody who's talked. And so I say very quickly, ma'am, please tell me your husband's healthcare status, what's going on with him. He's dynamically ill. I need to know what to do or not do next. And she said, well, Dr. Murphy, he's got leukemia and bad congestive heart failure. He's been on a breathing tube before. And just this last week, we sat down and did this thing with our doctor. And my husband said, under no circumstances did he ever want to be on a breathing tube again. And I said, I can honor that. She said, he doesn't even want any CPR. And I said, I can honor that. She said, and we're Jehovah's Witnesses, we don't want blood. I said, I can honor that. Looking at him, that was part of the problem. His mucous membranes were the color of the sheet. So I said, let me go back in and stabilize him. I'll bring you in. But I went back in the room, and the man was no longer tripoding in respiratory distress. He had gotten relaxed, and he was looking up toward the corner of the room, and his respirations were dropping. He was in respiratory failure. So knowing that I had reached maximum therapy this man would allow, I went and got his family, and I began this process. His 6 adult children had shown up. And I said, I'm so sorry to come and tell you this, but if we're going to honor your dad's wishes, and I think we should, you need to know that he's showing dying signs. I've got him on the maximum support that he wants. But you can trust in me. I'm going to assure his comfort and dignity. And let me tell you what we're about to see in this room. I prepared them for the pattern of dying that would occur, what he would look like, what his skin would do. And I said, I'm going to make sure that he's comfortable with medications. Do we need to call in a chaplain? I need someone to support you in your beliefs. Then I told the family, please come in and hold his hand. What needs to be said? Thank you, I love you, goodbye, forgive me, whatever comes to your heart. And so all 6 children came in the room and the wife, and they formed a circle around this man. And I gave him little pushes of morphine. And the eldest daughter held one hand and his wife held the other hand. And this is what the eldest daughter said. She said, Daddy, I want to thank you for taking care of Mama all these years. And I hope my boys grow up to be like you, because you've been an honorable man. And I want to thank you for working 3 jobs to feed us and put us through school. But today's your day, Daddy. Dr. Murphy said it's your time to go. And we love you. We will love you forever. And I'll see you in paradise. And she kissed him on the cheek. And 5 minutes later, he died. And it was good. It was holy. It was sacred. And it was just as it should be for our patients. I hugged this woman and I said, I want to thank you so much. You've given your daddy a good death. And in the end, it's the most any of us can hope for. I said, I'd be so honored if one day my daughters can hold my hand and say the same words. What a blessing. And I looked at my staff and I said, they just showed us how to do it. All of our patients deserve this. So here's the bottom line. It's up to you. Now, if you're lucky, you'll never see me again. And after all this, I'm sure you're happy about that. But here's the deal. It's up to us. It's our jobs. What we do and do not do matters. Our thoughts and beliefs create the system in which we live and work, in which we will ultimately die. You and I and our children will die in the hands of the medical system that we've created together, my friends. And I hope that it will be a good death. And I thank you for your time. Thank you. I accept questions, comments, and Rotten Tomatoes, and there's some other resources I passed out too. Yes, sir. Are you just stretching?
No.
Yeah.
I really appreciated that talk. And one thing I wonder, in the case of somebody that's hospitalized in the ICU, that you described, even though probably it would have been better in a room on the floor. Some hospitals have bioethics on
Yes.
staff. I just wondered if you wanted to say something about the role that they can play.
Yeah, sure. So I'm on the ethics committee at our hospital. I wrote an ethics chapter for emergency medicine on the end of life. And I'm not trained in ethics. I fell into ethics because end of life issues is very much an ethics topic. So if a patient or family member is in crisis about the decisions being made, an ethics consultation may be paged. If the physician is having an issue, like they don't want to continue life supportive measures, but the family wants it, an ethics consultation may be called. And nurses who are in moral crisis about the care they're providing, who feel that it's wrong, anybody along this entire spectrum may call an ethics consultation. Most ethics consultations work the same way. A nurse, social worker, or physician comes in and assesses the situation and tries to get everybody's perspective and to come to some consensus, right? Everybody's trying to avoid medical legal issues. And so sometimes in our ethics committees, we are able to come up with an answer or solve a problem. Sometimes we are not. So we can't solve all problems with it, but it is certainly available.
How do you handle responding to the patient in the speech? If I don't want to know.
Yes. Okay. Right. Okay, so certainly many ethicists will say that you should ask the patient what they want to know about their healthcare issues. And most palliative care doctors are trained to say that. And I have a slightly different stance. I tell people you can't make a decision for yourself without knowing the bottom line truth, and I say, I'm so sorry, I'm going to tell you what I know. So I kind of override that because I really feel like that they can't be a shared partner in their care unless they know the honest truth. Now, some cultures want a certain family member to be the decision maker that receives all the information and let that family member be the decision maker for that patient. And I actually generally try to respect that. So that's kind of an exception to the rule. Is some indigenous third world countries, that's the norm for them. But I do try to make a point to getting the truth to the patient as well. Many ethicists would disagree with me. Thank you, guys.